Well, we've learned a lot about healthcare in the last 12 months. Personally, I could tack another year onto that from dealing with my mother's health issues. And I now know about immunity and vaccines and viruses and cancer and dementia and orthopedics and aging and nutrition and all kinds of things I didn't know about 24 months ago.
Life's a teacher like that, Holland. You know, sometimes we would prefer that we weren't educated through our life experiences. I've learned more than I would ever have imagined. I've actually worked as a contact monitor for the CDC this summer. That was my summertime teaching gig job. I'm definitely not an expert on public health, but I have run up on a number of folks who in social media apparently do have expertise in the public health arena.
Right? Which is why we need a podcast episode on the words and stories we use to talk about public health. What vocabulary and what narratives lead us to the truth and which ones don't.
Hi, I'm Holland Webb.
Hi, I'm Amy Boland.
And you're listening to The Afterword, a conversation about the future of words.
So we have Kim Nelson, a public health advocate, who's joining us tonight. Kim, can you share just a little bit about what you're working on right now?
Yeah, so I am fresh off the campaign trail. I ran for Congress here in the upstate of South Carolina. I was the Democratic candidate for South Carolina's 4th Congressional District. And so right now I am getting back into the public health world while also, like every other parent, but especially mom in the country, dealing with 2 little kids and, you know, what do we do with their educations right now? So I am kind of back in the civilian world at the moment, which is nice on days like today.
All right, for sure. Well, we're glad you could join us, and thank you for coming on such short notice.
And joining us is Dr. Eric Brenner. He is a public health physician and medical epidemiologist in the School of Public Health at the University of South Carolina. And he's joining us for this very, very timely conversation. So welcome, Eric. What is occupying your days right now?
Well, first, thank you for having me on your program. It's a treat to be here with you. So as someone who's had a career working with the communicable disease control programs, I've naturally become involved this year with some COVID matters, although in a broad sense, I'm retired. I've been giving talks to lots of groups about COVID, started at the USC campus last spring. I worked for the state public health agency, that's DHEC, on a part-time basis, helping them do projections of data to see where the pandemic might be going in our state. I'm spending time now trying to write an introductory textbook on epidemiology. Not that there aren't lots of such books out there, there are lots. This one is a book with a twist. It's going to use COVID for every single example, for every single calculations, combining COVID and epidemiology. And finally, I do teach infectious disease epidemiology at the School of Public Health at USC just in the fall, getting ready to teach it again next fall. And starting next year, we may be giving an online MPH course as well. There'll be a challenge there to be able to teach virtually.
Wow, that is a lot. Do give us the acronym. What does MPH stand for?
Masters of Public Health.
Very good. Thank you. Because some of us like acronyms, but we aren't quite up to all the speed on phone. So thanks for sharing that.
Right.
I remember being at a conference once, and someone raised her hand and said, I'm getting confused with all the acronyms that we're seeing. And the lady on stage said, oh, that's no problem. We have a thing called an LOA. It stood for list of acronyms.
I feel like
anyway,
in public health,
sorry?
we tend to speak in acronyms. So it is a habit that we unfortunately need to break sometimes.
I think every organization has its acronyms.
Probably. All right. So just to give us a little bit of an idea, can you give us the 60-second Cliff Notes version of how you got into public health? We'll start with Kim, and then Eric, if you jump in.
Yeah, absolutely. So like a lot of millennials, I did not go into the field that my undergrad is in, which is French. I landed in sales and I found myself in banking. That led to me putting my 6-week-old daughter in daycare. She's baby number 2. And she went in February. And so after she'd been in for, I think, about a month, maybe not quite, the flu broke out. And there was a baby who was old enough to be vaccinated in her class that wasn't. The baby in the crib next to her caught the flu and was so sick that he was actually hospitalized. And I just thought, this is nuts. We have a vaccine. Why are we risking our kids? Why are we letting kids get sick? And I didn't really do anything with it at that point. Fast forward, I realized sales, banking, it was not for me. I needed to do something with health. And I went back to school. I quit my job. We came back home to South Carolina, and a very short version is that one plan didn't work out. And so I looked around for another way to get involved. That's how I founded South Carolina Parents for Vaccines. I was unpacking an apartment, saw a headline that said religious exemptions, which kids need vaccines to go to school. And if they, for some reason, can't or don't want to get a vaccine, they need an exemption. And it can be a medical exemption or a religious exemption. And it said religious exemptions in South Carolina had grown 70% in a 3-year period. And I'm like, we didn't get 70% more religious. Something else is going on here. And that led to me starting South Carolina Parents for Vaccines, educating parents on vaccines and vaccine preventable diseases, lobbying the state for better vaccine policies, to tighten up those restrictions, to eliminate them because they are not necessary. Ultimately, got my MPH, as we just discussed, from South Carolina. I was a 2019 grad, and I love health policy. So that's kind of my home in public health. Was that 60 seconds?
Thank you so much.
And I'm delighted to hear.
I think that counts as Cliff's Notes.
Okay.
It's great that you were a French major, Kim, because I majored in French myself as an undergraduate. Oh. Bonjour, ça va bien?
Oui, ça va bien et tout.
Très bien. Well, very good. Anyway, I'm from California originally. Was a French major, studying French literature at the University of California at Berkeley. Then joined the Peace Corps, which was a fashionable thing to do in my day, coming from Berkeley in the 60s, and taught in French West Africa, or in the Côte d'Ivoire, or the Ivory Coast, as we say. I taught junior high school there for 2 years. Then came back and went to medical school and had training in internal medicine and then infectious disease, but wound up not staying very long in clinical medicine and quickly got into the public health side of medicine. So I've had the chance to work at different levels in public health. At the state level in South Carolina with the Department of Health and Environmental Control. At the national level, I worked with CDC for a couple of years in Atlanta. And I had a chance to work with the World Health Organization in Geneva, Switzerland also for a while with their immunization program. We'll discuss, since immunization is a common interest I have with you, Kim, so we'll have a chance to discuss that later. I'm now retired from my health department work, but remain active with teaching and consulting in a number of ways.
I'm so excited about this, Holland. This is going to be so much fun. We have a deep bench of knowledge, but not everybody shares this deep bench. So for our listeners and those who might need a little bit more tutoring, myself included, let's get some terms underway. We've mentioned this one a couple times, and it sounds like one that, oh, I should know what this means. But really, what is public health? Either one of you, jump in.
Kim?
Well, I was actually going to defer to you because it's, to me, it is just, it's the care of an entire community. And not just health care, it's emotional care, it's spiritual care, it's mental and financial. It's all of those things that come together and determine how healthy we are or are not. And it's on a community scale, but that is a very loose interpretation. And I would love to hear Dr. Hello, Balto.
Oh, yes. Well, maybe we could have a complex discussion, but maybe a simple example could put it in perspective. When most people think about health or a child, they say, "Oh, my child has nausea, vomiting, and diarrhea, and is feeling sick. I'll take him to the doctor," and that's individual health. But let's imagine the following thing. Let's say you have a 10-year-old with nausea, vomiting, and diarrhea. But what if it turns out that 8 other children in his 3rd grade class also have nausea, vomiting, and diarrhea? What if it turns out that it's not just the 4th graders, but also the 3rd, 4th, and 5th graders, all attending the same school, but not the 1st, 2nd, and 3rd graders? There's something going on here. But what if it turns out that this is happening not just in one school, but also in the neighboring elementary school? So if you had this happening this week to 85 children, and next week 95, and the following week 105, you could think that there are 105 individual health problems going on. That could be 105 doctor's visits. But there's something else going on affecting a population, and in this case, the population are the kids who attend the same school. So if you think about this as a public health problem, that would mean that you'd want to do such things as improve surveillance to find out what is going on. Since this is a little bit a mini epidemic, you might just call it an outbreak. You would do an outbreak investigation. Why would you do that? You do that to find the cause of the outbreak, to do 2 things. First of all, to stop other kids from getting sick, but secondly, to prevent the same kind of thing from happening again in the future. So I give this as an example of how this goes beyond the one patient, one doctor visit to think about population in general.
I love that. And I really appreciate your definition, Kim, just the care of the community, all the things involved with it. And then Dr. Brenner kind of explaining how that would get teased out. Excellent. All right. How about this next one? Epidemiology. We've heard a lot of that on the news lately. Dr. Brenner, I would guess you would probably want to go first.
Well, within the realm of public health, there are many disciplines, and actually politics can be one of them. Kim, since you've had one foot in politics and one foot in health, and being able to communicate with the media would be another one. But in some sense, epidemiology is sometimes considered to be the core science of public health. And you can think about it if you just break the word down, epidemiology. So ology, well, like geology is the study of the earth, or zoology is the study of animals. So ology is the study of something, the study of what? So epidemi, that's from the Greek word demos, meaning population. Like democracy is the rule of the people. So it's a study about something dealing with people. And what does epi mean as an epidemiology? Epi means upon. For example, on top of the layer of skin is called the epidermis, which is on top of your dermis, or on top of a gravestone is someone's epitaph. So epidemiology, in a literal sense, means it's the study of something which is upon the people. Now, I don't mean the rain or the sleet or the snow. I mean disease or plague on the people. So that, broadly speaking, is what epidemiology is all about.
Holy cow. I'm educated. Kim, anything you want to add to that one?
No, I think he really covered it for us there.
I love words.
I'll give you one final twist, which you won't find in any epidemiology book. When you say epidemiology, that's the study of something upon the people. But I don't mean the weather. We really mean disease upon the people. So a better term would be to think about what pathologists study. Pathology is the study of disease. So the real word should be pathodemiology. So Kim, what we should do is write a letter to the Dean of the School of Public Health and say, please change the course from being epidemiology to being pathodemiology. That would really explain much better what it means.
I like that.
I'll let you two get on that. Good for you. All right. How about this one? Social determinants of health. And I think, Kim, you kind of tapped into it with your first answer. So I'm going to let you go first.
Yeah. So social determinants of health are really, Balto is going to help me out here. They're really all the things that come together. Our lives don't exist in a vacuum, right? Our health is influenced by our education. It's influenced by where we live. It's influenced by, how much money we make. And the social determinants of health it speaks to those other parts of our lives that shape how healthy we are or are not. And to me, it's where when we look at addressing health problems, we do have to go upstream. Because you can't, it doesn't matter if you have, diabetes, for example, if you're earning a wage at a job because you have a high school diploma and no further education, and that wage, you cannot afford healthy food, you cannot afford your medication, what have you. So it's thinking more broadly about what does and does not make us healthy.
That's excellent. And by the way, for all of our listeners who cannot see this adorable dog, Balto, who belongs to Kim, we may have to include Balto in her screenshot as we share this episode when we drop this, when you all see it. So
he's definitely answering questions right alongside you there.
Absolutely.
My kids let him in, and I don't know if you saw me a minute ago, like, go, leave. And they let him in, and now he's stuck in here. So,
well, he's part of your social determinant of health. He's now in your environment. All right, let's move to our last one: communities, populations, and solutions. Somebody give that one a go.
Kim, this one's for you.
Communities, what was the rest of it?
Populations and solutions, which you kind of already delved into a little bit.
Yeah. So, population, it's not just, the population of Greenville, for example, and I'll use that because that's where I am. It can be a certain school. It can be, a certain street. It can mean a lot of different things. It can mean an age group. It can mean, whatever. We can define it however we want. And this touches really more on what Dr. Brenner does with epidemiology. But it's the idea that there are certain groups of people who have things in common that affect their health.
Yeah, this is, in a way, this overlaps with the previous question about social determinants of health. Sometimes we think about, we're in the middle of COVID now, so we're thinking that the virus is determining our health. Okay, or other viruses. It could be measles virus or influenza virus or Ebola virus, whatnot. Then there are physical determinants of health, exposure to toxic chemicals or radioactive waste, for example. But then the social aspect, as Kim mentioned, that can be all kinds of things. Sometimes they can be subtle. For example, in some communities, there may not be good, safe housing or local food markets. Actually, in Columbia, we had housing development that had to be shut down because the gas pipes were not safe, and some people were getting gas in their houses. Or in some places, usually in populations which are poor, there may be so-called food deserts. That is, there are no supermarkets there, and people can't afford to buy healthy foods. Access to healthcare services. I mean, that's also a social determinant. We have counties in South Carolina which actually currently don't have any hospitals, and few physicians there. So, and public safety and many such things. So we can see that it's not just a matter of a virus, not just a matter of toxic substances, but the whole social environment can affect your health as well.
Thank you very much. This is, I definitely know a lot more than I did 15 minutes ago. Would you share with us, Dr. Brenner, a real life example of public health work?
Now, I'll share two. I had the opportunity to work with the tuberculosis control program at CDC. In fact, for a couple of years, I commuted weekly from Columbia to Atlanta. So I know that highway very well. And Kim, you're with 2 children. I left my wife and 2 little children at home, and I would leave at 5 o'clock in the morning and drive to Atlanta Monday morning and race back for Friday night. But I worked there with a program where they have I would see a lot of, quote, subject matter experts, SMEs, who know everything about tuberculosis backwards and forwards. And what our function there really was to do was to help all 50 states manage their tuberculosis control programs. The most exciting part about that was the opportunity I had to travel with a small team, sometimes with someone else from CDC or someone from the American Thoracic Society, and do what we called a program review. We did this in small states like Rhode Island or North Dakota, Iowa, but sometimes in very big, complicated places like Los Angeles County, New York City, most complicated of all, New York State, and find out really what was going on there with their TB program. How many cases did they say they had? How many cases were there really there? How good was the laboratory work that was done to confirm the cases? How good was the medical supervision? People think, oh, if someone with TB is going to see the doctor. But after a few weeks, they feel better, they stop taking their medicine. So what we had to have in place is a system where public health nurses would observe every dose of therapy for every single patient. And that's not all, because someone who has TB can communicate this to other people in their family, other people at school. Someone has to do a contact investigation to find out what's going on. Who's going to do all this? Who's going to train people to do all this? How and who's going to pay for all this? So there are funding issues and teaching issues and medical issues, so many different things all rolled into one. That was a great learning experience, but also a chance to see what's going on in public health, sometimes behind the scenes, as it were.
Thank you. That's fantastic. Kim, do you have an example you could share with us as well?
I think, for most people, their first exposure to public health, because when public health works really well, we're in the background. You don't really see us. We don't broadcast a lot of our successes. And I think that's to our detriment, unfortunately, as public health professionals. So with this COVID pandemic, a lot of people are seeing all of this process of, contact tracing and working on a vaccine, and what does emergency use authorization mean? All of those terms and all of those systems and all of those strategies, they're seeing them play out. I think the thing that tends to strike the public the most is how the recommendations on masking evolved over time, how it went from, first, you don't need a mask because we don't think you do, to you don't need a mask because healthcare providers don't have enough, so we need to save the ones we have for them, to yes, you need a mask, make it cloth though, because we still don't have enough for them. And now here we are wearing N95s or KN95s or double masking. And, seeing that process, which it frustrates some people. And, I can certainly understand why. It's like, do they not know what they're doing? Do they not know what they're talking about? But that's the scientific process. We're seeing that process play out in real time. And we don't always get it right the first time. That body of knowledge is evolving. We are learning on the fly and making recommendations based on the best information we have at the time sometimes.
It's really fascinating. A couple of weeks ago, we did our episode on vaccines, and we looked at some of the ways that vaccines were developed starting way back, whatever it's been, almost 150 years ago with smallpox, and how these vaccines developed and what sort of the responses of the public were over time as something new came along, particularly as there were high-profile stories of somebody dying because they took the vaccine, or people dying in spite of taking the vaccine, and sort of seeing how that happens and how the public responds. It's a really interesting, especially when you start talking about injecting something into somebody.
I'll pick up on that for a moment, since we're talking about vaccines. I had the opportunity to work, I think I mentioned, with the World Health Organization and their program called the EPI, Expanded Program on Immunization. And their target population were the children of the world. So the world now has about 7 billion people. So how many babies does that lead to every year? About 140 million children. In well-to-do countries such as ours, we can more or less take care of them, although we have challenges, as Kim knows. But in many countries, vaccine coverage some years ago was very, very low. So the goal of the EPI was to gradually increase vaccine coverage, but had to be done in such a way that all the details were taken care of. For example, if you are in Nigeria, the vaccine is not made in Nigeria. It's coming from London and has to be kept at a certain temperature from the time it leaves the factory all throughout the plane ride till when the plane lands in Lagos, then goes up country to a small health center and goes out to a village where there's no electricity. How would you keep the vaccine at the right temperature every step of the way? So that's public health in a large sense, looking at those kinds of things. And then how would you know what proportion of children have received vaccines? In the US, it's very simple. You just go to the school nurse who has a list of all the children in the school, and she can check their vaccine card. If you're in Cameroon or Gabon, and you say, oh, is there a computerized list of every children in this village? No. You're going to have to do some kind of statistical survey. What are the statistics behind that? So you can see there's a whole infrastructure there that has to take many disciplines into account: the supply chain, the cold chain, the community acceptance, statistical methods, and so forth. And that's public health, if you will, in a very large sense.
Wow, that is a large sense. You know, both of you have kind of touched on something. You know, one of the things I heard that was a remarkable statistic, and I kind of love statistics. So Kim, I appreciate the 70% religious exemption statistic that you threw out. I'm just kind of like, wow. But one statistic I did hear was that the number of people who got the flu or children who died from the flu this year has been dramatically reduced. And so, you know, we've been doing a lot of hand washing and wearing masks and that type of things. And these are maybe some fundamental health practices in public health that have been positive. Kim, what's something that you would like to see continue as we move forward?
I would love to see this culture around, oh, you're sick, you should stay home. I would love to see us kind of just for once take that time, take that respect for others, respect for the people we work with or we go to school with or live with. I think a lot of people are waking up to the reality that viruses are unpredictable. We do not know who's going to get the flu and end up in the ICU. You might be that unlucky person, and certain things obviously make that more statistically likely. But there are people who are young and healthy who die from the flu every year. So I think just that kind of value shift, and those are hard to do. Unfortunately, they do take big events like a pandemic. But, you know, normalizing mask wearing, normalizing, I'm in public health. I am a vaccine advocate. And I was never the mom who kept hand sanitizer in my car. That just wasn't something that I did. But now it's the first thing, you come out of the store, squirt. Just little things like that I think are ultimately going to be here to stay. Kind of give me hope that maybe our seasonal flu outbreaks going forward hopefully won't be as bad.
I really appreciate that, especially as teacher in the classroom and with that kiddo that the parent has sent to school. And, you ask them, did you tell your mommy that you weren't feeling good? Yeah, she said I wasn't that bad, just to go. I'm just like,
Right. So we it's so interesting to look back, not just at the current flu season. So here we are in the 2021, but going back to 2020, that would have been the 2019 to 2020 flu season, which has started out normally November or December. By January and February, we're having flu. And then COVID along came in March and April, and flu just about disappeared. It was so interesting. So as Kim has mentioned, at that point, not perfect for sure, but social distancing and masking and hand washing came in. And we are assuming this is one reason we've had almost no flu this year. It's really just astonishing. Your listeners might like to go to www.cdc.gov/flu. Go there every week, and you can follow what's happening with influenza in all 50 states. And you can see how many hospitalizations there have been, how many doctor's visits are from influenza-like illness, how many deaths there have been, and so forth. So in this case, COVID has been a tremendous public health burden, not to say disaster, but seems to have indirectly helped with flu. So as Kim says, we hope that in years to come, that we will take some of the same precautions that we're now doing. Masking has been more common in certain Asian countries than it is here. I mean, we often see people on the news in Japan and China wearing masks. This is the first time we've done this. And the other thing we need to improve, and Kim, we're counting on you, we need to improve our influenza vaccine coverage. That is, we have 300 and, let's round off, let's say 300 million people in the US. Flu vaccine is recommended for everybody in the country who's more than 6 months of age. So if you have every year 4 million babies born every year in the US, new babies, half of those are already 6 months old. So that's 2 million. There are 2 million children in the country who are under 6 months of age. That means total population, 300 million minus 2 million, 298 million people should have gotten the flu vaccine this year. And they haven't. Not even that many doses haven't even been made. So we have some progress to make for sure. And if we can keep some of the momentum going from COVID, we can have an impact, a public health impact on influenza deaths, and not have to have tens of thousands of people die from influenza and influenza-related complications every year.
That's great. Well, let's hope that we can move forward in that. Go ahead, Kim.
One thing, none of this happens without systems, without policy change. That's the thing. You might tell your boss, I don't feel great, I'm not going to come in. But if your boss is like tough, you're going to lose your job. It doesn't matter. So that's, I think, one of the biggest takeaways that a lot of the COVID relief packages, stimulus packages, they've stipulated that employees must be given time off if they're exposed to COVID, and they can't lose their job as a result of that. Those are the things that really need to stick around for these changes to stick around.
I like very much that notion of importance of policy. In fact, that reminds me of a certain publication from 20 years ago, which tried to summarize public health in 3 words. One is assessment, find out what's going on, what are the health problems. Secondly, policy development, that is based upon what you've found out, there should be some policies that are put into place which can address those problems. And the third thing then would be assurance. How do you assure, how do you evaluate, how do you monitor that those policies are in effect that can affect those outcomes you're trying to improve? So I like that very much. Public health assessment, policy development, assurance, each of which could have separate subfunctions, but that's a nice little way to summarize the process.
It seems like most of public health is a logistical challenge or maybe an educational challenge, that we have the research and the resources already. We're not most of the time, COVID being an exception, but most of the time we're not talking about diseases we don't know how to cure or something that's really expensive to solve. But either we can't distribute the resources, as you were just talking about, getting that vaccine from London to a remote village in northern Nigeria, for instance, or people simply won't use the resources once they're in place. And misinformation can play a key role here. So what would you say is the greatest challenge to advancing public health in the U.S. and abroad?
You mentioned one of them just now, which is misinformation. 20 years ago, we didn't have social media, didn't have Facebook and tweets and whatnot. So for the most part, and even on the evening news, you had Walter Cronkite. That's before you were born, probably. There were a few sources of news. So there's one of the great challenges we have now is this imbalance between good information and misinformation, for sure. It's not that there isn't good information out there. There is lots of good information. So one of the things that we maybe need to do is to educate young people better and educate parents better how to evaluate the quality of the information they're getting. One off-the-wall suggestion might be to have epidemiology taught broadly, not just for people getting MPHs, Masters in Public Health, or PhD in Health Services Policy and Management, but could even be taught to undergraduates. In fact, I remember an article written some years ago by David Fraser, who had been a division director at CDC, then moved to become president of Swarthmore College, which is a pretty fancy, high-end undergraduate college in the Philadelphia area. And he wrote a wonderful article in the New England Journal about reasons that you might want to make epidemiology a liberal arts subject, and saying that in a broad sense, it combines biology, the scientific method, data collection and analysis, linking all this to public health in a broad sense, but this provides a tool for clear thinking about what are data and what is just anecdote, something we really need to do. So maybe in the future, Kim, when your kids go to college, maybe even if they're majoring in economics or French literature, they'll take a course in epidemiology too.
I don't doubt she's already probably teaching her children that right now.
They make this wonderful vaccine and immunology book for babies. So yeah, like a bedtime story. No, I agree. I think it starts with, if not epidemiology in and of itself, at least those principles, that process by which you assess information, discover whether or not it is true. We need to start that really in elementary school, building that foundation for people. But as for, who's making these decisions now, it's adults, it's not kids. And that's really where we need to focus a lot of our efforts. Unfortunately, social media, it's the great equalizer, right? It gets good information out there in a really accessible way that we haven't previously been able to do. It also gets bad information out there in a really hard to uproot kind of way. And the way social media works, it's monetary. So until we clip their wings with, ending financial incentives for pushing ads or, selling unregulated supplements, whatever the case might be, those things that really incentivize someone to put bad information out there. You don't need a vaccine. It's toxic. Buy my thieves oil. We're going to keep seeing this problem come up over and over again. And a lot of that is found in mom groups. It is found in Instagram influencers. And, I'm a millennial. I am a digital native, and I'm an old millennial. So I'm not, I'm going to be 36 next month. I realize to everyone here that might sound young, but compared to a lot of people on social media, that's kind of older. It's old enough to have not had all of this all the time, and to remember what life was like before. And, seeing this rise of the Instagram influencer, it's really changed, I think, how a lot of women my age who are navigating this, it's overwhelming to be a parent. It really is, under any circumstances, even more so when you've got 24 hours a day, 7 days a week, information just flying at you every time you open your phone. And so we really, really need to find a way to compete with that. And that's something traditional public health departments haven't had the resources to do. One anti-vaxxer named Larry Cook, he has a Facebook group. I forget how many hundreds of that. I think it's like 300,000 people in it at one point. He spent, I think in the year 2017 or 2018, he spent $75,000 in advertising, maybe that month, or maybe, I don't know if that was for the month or the year, but either way, that is a huge chunk of change that DHEC can't compete with that. The CDC would even have a hard time getting people to listen, but that's where people are going for their information. And we can either fight that, or we can lean into it.
Wow. It almost sounds like the education and the teasing out of misinformation is its own pandemic.
Yeah, it absolutely is.
I was going to jump in on that. I remember many years ago being at the South Carolina, it used to be called ScanPost, South Carolina Association of Nonprofit Organizations. They've got some trendier names since.
Together SC.
There was a man talking about branding. Together SC, thank you. There was a man talking about branding, and he darkened the lights in the auditorium, and he showed us a commercial for Diet Coke. And after that, he stood up on the stage and said, "Now, how does your last ad campaign compare to that?" Well, of course, everybody there had just gotten some horrible little thing together that was very maybe true and very educational, but that was in no way compelling like this ad had been. And he said, that's what you're competing against for your dollars. And I've thought about that several times. People who are attractive and well-spoken and know how to present themselves in the media can attract a large following that someone who has deep expertise, but the inability to communicate, or they don't have the right look, they just can't get the facts or better information across, no matter what the discipline is. It's not just a public health issue.
No, and what a lot of those influencers are selling, it's not the product itself, it's the lifestyle, it's the community, it is the, if you subscribe to this nutrition program, for example, because that is a whole different, can of worms. You too will have the mom goddess hair and the perfectly behaved children and your home that looks like it came straight out of a Pinterest board. Like, that's what people want. It's not the stuff. But we don't communicate that way because we think in terms of data, we think in terms of statistics, but most people don't.
Yeah. Wow.
Most people think in terms of stories and images.
Yeah. As we close up this first episode, because we have got a lot to continue talking about with both Kim and Eric, what is an essential element we need to understand about the stories behind public health? Eric, I'm going to start with you.
I'm reminded that in 1999, at the end of the 20th century, the CDC came out with a series of articles saying, all right, let's look back at the last 100 years and really what have been the major public health achievements that we've had. And since I work with communicable diseases, I was happy to see that 2 of the 10 related to communicable diseases. Number 1 was actually vaccination. Number 4 was control of infectious diseases. But then they had other public health accomplishments, safer and healthier foods. Remember, I was talking before about kids getting food poisoning in school cafeteria, healthier mothers and babies, decreased infant mortality, family planning, recognition of tobacco use as a health hazard, a whole series of things with importance. I was struck by one of the 10, which I never would have thought of, motor vehicle safety. I was thinking, oh my goodness, what are they talking about? Why is CDC talking about motor vehicle safety? But then when you think, but then they showed statistics how over the course of 50, 60, 70 years, the numbers of accidents per 1,000 miles had gone down. Why was that? Well, some of it had to do with roads, divided highways and traffic lights and pedestrian crossings and speed bumps and speed limits. Some had to do with cars themselves, that's engineering, seat belts and headrests and airbags and so forth. And some had to do with legal measures. Shouldn't drink and drive, for example. In fact, you can get a ticket or lose your license because of that. And nowadays, in some places, you can't text and drive and so forth. So through a combination of work done on roads, road safety, on vehicle safety, and legal matters, we're able to bring down a severe public health problem, which was deaths from motor vehicle accidents. So I thought that was very, very instructive. Most people don't think in those terms. It would be helpful. I suggest as an undergraduate, but I think Kim's idea is, oh my goodness, you can start out in high school or elementary school or have a picture book for little kids about how to be safe and so forth. So I think there's a lot to do in that area still.
I love that. I can remember driving around in cars without seatbelts, and there were no requirements at all. And so that's a perfect example of public health making a difference.
But let alone baby seats you need now for your little ones.
That's right. That's right. How about you, Kim? What's your essential element?
Oh, I think we take this field for granted. The fact that we can go outside and the air is relatively safe to breathe. The fact that we can just turn on a tap, and in most places in this country, you can trust the water coming out of it. All those little things like, I buckled my kids in a car seat to run to the grocery store today and pick up curbside. And, I had my seatbelt on. All these little facets of our life, our day-to-day routine that we do not even think about. Those were major public health milestones. And we take it for granted. And the problem with taking things for granted is that you then devalue them. You devalue the systems that enable them. And that's why we are kind of in the situation we're in with COVID. It's decades worth of budget cuts as a result of public health working really well. Because when something works well, you don't want to throw money at it. You want to throw money at some new military airplane instead. And so to me, it's understanding that none of this happened by accident. It was all hard won in its own time. And to recommit to making those investments so that things get better, so that we don't regress.
It's interesting to think also about, you mentioned anti-vaxxers, but now we've had also anti-maskers this last year. And I think in some states there have even been demonstrations at the state capitals and governor's offices, people coming in with guns saying, this is a free country. Nobody can tell me to wear a mask, even though they may be spreading infection to others. But if this is a free country, why is the government telling you to drive on the right? Suppose you say, well, I'd rather drive on the left. I don't want anyone telling me which side of the road to drive on. No one would think of doing that because it's so, well, there could be a head-on collision. You may both die. So we are used to having certain restrictions put on our everyday lives. We just don't notice them anymore. And these kinds of things need to be brought out also to the general public, starting in elementary school.
Perfect examples. Wonderful. I love that segue.
All right. And we are wrapping up now our first part of our conversation on public health and epidemiology and the stories and words that inform what we believe about it. So we'd like to say thanks to Dr. Eric Brenner and to Kim Nelson, MPH. This is such a needed conversation. And for everyone else, while you wait for part 2, please go to theafterwordpodcast.com and become a subscriber. Leave us a review on Apple Podcasts or wherever you get your podcasts, and tell your friends about us. As always, you are welcome at our table.